Hello everyone, thanks for joining us today for episode number 2 of ImmuneKicks, where our mission here is to move beyond the noise and explain the real deal of what's going on with the coronavirus situation currently, and to show that we really are in a much better position right now. Things are actually much more in the right path than some of the mismessaging that's out there and what you'd be led to believe by what's being reported in the public sphere. And that's where we're going to stick to the medical studies, the published literature, and really go into in detail so you guys as concerned individuals, concerned citizens of the country can look into and see for yourselves about some of the objective, verifiable medical information that's out there and understand really what's going on right now. So we're going to focus on 2 key topics today with episode number 2. One is going to be, we talked in detail about the extensive numbers of tests that are being done every day, over 2 million per day that are being done. We talked in episode number 1 of our series, and we're going to go into more detail about what are these tests. And it's a PCR test. You might have heard that term. You may be quite familiar with it. But what exactly is that test? What are the pitfalls? And what is the problem with reporting that particular test in terms of declaring these absolute numbers? Concept number 2, point number 2 we're going to talk about in this video is in-hospital mortality. How many people who are hospitalized are surviving or not surviving, dying, and we'll talk about how that's also made substantial progress between spring 2020 to late 2020, fall, winter 2020. So to kick off real quick is that there were a couple of key concepts from episode number 1 to kind of segue into the discussion about PCR tests. One is that, again, the prevalence. The prevalence is, unfortunately, the virus is so common in the country. The real issue that we need to do to tame the situation and get back to normalcy, which is ultimately the goal, I think, of everybody, is to get back to normalcy or very close to it, is by getting the prevalence under control. And the virus is unfortunately very prevalent, and that's why as we test more, now 2 million tests per day nationally that are done, you're going to get a lot of positive tests that are reported, number 1. Secondly, we talked about is that reassuringly is that the infection fatality ratios, the risk of dying from COVID if you were to contract it, is fortunately quite low and far less than 1% for the vast majority of folks that are out there, especially if you're less than age 70. And also don't have one of these major comorbidities, the big 4 comorbidities, such as significant cardiovascular disease, active pulmonary disease like emphysema, immunocompromised state, obesity. So if you're not in one of those categories or elderly, then your risk of surviving COVID, your frequency of surviving COVID is actually very, very high. So the risk of dying from COVID is far less than 1%. So those are a few of the key concepts. And third is that if you look at the aggregate numbers in terms of how many people have tested positive currently, how many people have a positive test right now in the country overall. And we talked about how the number is roughly about 2%, 2.2%. So in other words, roughly 98% of the country right now does not have coronavirus. So those are some of those key concepts from episode number 1, and please check out episode number 1 if you want to see that in much more detail that we talk about so you guys can see it for yourselves and how those numbers have been published in the literature, how those numbers are published and reported by the CDC, etc. And you can dive into it in great detail like we did in episode number 1. So now what is these tests that are being reported? We talk about these overall absolute raw test numbers are fundamentally meaningless without knowing the denominator, how many tests are being conducted per day. So we talked about that extensively, and that you often normalize by tests that are being conducted and by national population. We have a big country. We have the 3rd most populous country in the world, behind only China and India. So that's why you have to account for how many people we have plus the testing frequency, and that's why when you normalize for those factors, you see that we're actually doing quite comparable to France, Italy, Spain, UK, etc. And that is not shocking. That's just reflecting the prevalence of the situation. But again, the raw numbers are meaningless. Furthermore, is that what are these tests, these PCR tests? So PCR means polymerase chain reaction. So what this test means, and it's important to understand because one key concept that we'll illustrate right now is that PCR assays that are positive does not mean a person is necessarily infectious. You might be infectious, but it does not necessarily mean you're infectious. So a positive PCR test does not automatically equate to somebody being infectious. And we'll show you the data for that, why. It is published in multiple journals, including Clinical Infectious Disease, which is a very prominent, peer-reviewed infectious disease journal. And we'll show you why that concept is critical to understand, because that's what's being reported in the public, is these positive PCR tests every day. So what PCR is that you're looking for evidence of the pathogen's DNA, such as the coronavirus, looking for evidence of the coronavirus's genetic code that's still being present in somebody's system, in their body. So, in other words, if you think about a virus in general, I'm sure you guys have heard this concept in the past, growing up, etc., is that when you have a virus and you're recovering from a virus, the virus might continue to shed, sometimes for several days, and actually it can go on for weeks to months. So, and that's been well established in the medical literature, that there are various viruses that have been tested and studied that they can continue to shed and be detected for even weeks to months after the actual clinical infection. The patient is no longer infectious, but the viral signature, DNA genetic signature, is still detectable several weeks to months later. And that's been known from MERS, which is the Middle Eastern Respiratory Syndrome virus, which was the coronavirus cousin. We knew this from SARS-CoV-1, which was the SARS form back in 2010. Number two, we know this from Zika virus, we know this from Ebola, we know this from influenza, all published in the medical literature. So because of that, this concept is not new, that a PCR assay that's positive, it detects minute quantities of the DNA signature of a pathogen, but it does not mean somebody's necessarily infectious. To know that, you have to know when were their symptoms, how many days later was the patient tested after their initial symptoms, and that's how you determine the likelihood of being positive. So the gold standard of somebody being declared infectious or not infectious is viral culture. So in microbiology plates, you have to be taking a patient sample from bloodstream, from saliva, from some other tissue in the body, and then seeing, does actual live virus grow in microbiology specimens? And then only by that is that's the gold standard test to say, yeah, somebody has actual living virus right now, growing right now, and therefore they're infectious. So that's the concept. So there's a critical study that was published that we're going to review right now, that was published in Clinical Infectious Disease last year, where they looked at for coronavirus specifically, SARS-CoV-2 specifically, what is the concordance of PCR assay positivity with viral culture positivity? How often is there that positive predictive value? And as you'll see, you have to see the PCR assay positive with proximity to the patient having had symptoms. So if you test randomly, like is being done across the country. People drive up to CVS because they think they had something 3 weeks ago or 4 weeks ago, or people are being screened when they go into hospital facilities around the country just as a default screening procedure, and irrespective of when or if they had symptoms. So those patients are often not infectious at all, and we'll show you right now in the data why. So to start off, before we dive into the study, is that what does the PCR test actually do? What is the nature of the test? To give you a little bit of an idea, concept of the fundamentals here. So the PCR assay is, again, looking for that genetic code signature of a given pathogen of interest within a patient. So think of it this way. You're going to take a minute amount of DNA code that's in a patient's bloodstream, nasal swab, saliva, wherever the sample may be taken from, and then amplifying that or magnifying that repeatedly until you get to a high enough level where you can say positive or negative. So the analogy that I like to use is that imagine you're looking for a shard of glass in your carpet, and you know it might be there, but you're not totally sure, and you can't see it directly. So what do? You get perhaps a magnifying glass, right? So if you magnify it with a good enough magnifying glass, you might say, aha, there you go. There's that little shard of glass that I was looking for. I don't want one of my kids to accidentally pick up or step on that shard of glass, right? So you may not see it normally, but with the right magnifying glass, you may detect that shard of glass. So it's kind of like that. What the PCR assay does is that, by analogy, you take a patient sample, like a nasal swab for coronavirus, and then you know that you think that perhaps there's minute quantities of DNA at some concentration present, but we need to amplify that enough to say with confidence, is the PCR test positive or negative? Again, not necessarily meaning that they have live virus growing, but is the PCR test positive or negative? So what the test does is that it takes the sample and heats it. So the DNA is like a double helix, right? And then the double helix will separate, or what's called denaturing, once the sample is heated. Once it denatures, then you use a different chemical called a polymerase, and basically that second chemical that's added will add a second helix again to each of those two strands that have been created from the heating process. So then once that's done, now you have two double helixes, right? So the two double helixes, that's one amplification step. And then there's that chain reaction. You keep repeating that. So 2 becomes 4, 4 becomes 8, 8 becomes 16, et cetera, et cetera, et cetera. So eventually, after you do like 25, 30, 35 repetitions, you actually wind up having millions to even a billion. So that's why you get enough of that DNA code replicated where the test can say with confidence that yes, indeed, a patient sample does have detectable DNA code or does not have detectable DNA code. So hopefully that makes sense. But that's the nature of the test. And as you can see by concept here is that that's why it does not test is the virus growing in culture. It just says is there any genetic code detectable in a patient sample. So that is the limitation of the DNA test. The power of the PCR test is that you can take minute quantities, amplify it, and you can find out, does the patient have a specific genetic signature or not? That's often helpful in cancer research, for example, where we're looking for genetic factors that are driving a particular tumor, for example. So that's something that comes up in our field in oncology very often, I should say. So that's the key concept of how the PCR test works as far as the power as well as the pitfall of this is that it's not testing for current viral growth, simply that there's still genetic material detectable. And like we talked about, like what we've known from SARS-CoV-1, from MERS, from Ebola, from Zika, etc., that and has been published in the literature, that virus DNA code can be detectable for even months afterwards, and that's normal because of how the body processes viruses. And as one more quick aside before we go on, is that, it's interesting, as a medical oncologist, we deal with infectious disease very commonly. First of all, infectious disease training is part of our training as oncologists. As one of my old program directors and directors of oncology used to say when I was in training, is that to be a good oncologist, you first have to be a good internist. And because part of internal medicine training, you go through infectious disease training, you go through testing, you go through board certification before you go into medical oncology training. So that's why it's very much part of our field, because we deal with immunocompromised patients all the time because their immune systems are down because of cancer, because of chemotherapy, etc. So hence, as part of my day-to-day practice, in addition to being a general concern as a physician, for the sake of the general public. So to go into this study, in this particular study, they looked at patients where they tested with a PCR assay, and they also did a concordance with a viral culture simultaneously, and then they correlated how many people had a PCR assay that's also viral culture positive versus PCR assay that's viral culture negative. Because that's the crux, right? We want to know, really, day to day, how many people have actual infectious coronavirus newly diagnosed today. We don't want to know how many people used to be positive and infectious and now are also positive. We don't want to know that combination. We don't want to know used to be infectious and are now infectious. We want to know who is now infectious, right? Because the former doesn't make sense. We don't care about who used to be infectious plus who is now infectious. I mean, there's no utility to that. We need to know who is infectious right now. And that's why this kind of study has a lot of value in understanding what is the limitation of the PCR assay in that regard. So we're going to show you the data from this study, and I'll show you that right now. And here it is. So this is published in Clinical Infectious Disease last year, and as you can see, the title, Predicting Infectious SARS-CoV-2 from Diagnostic Samples. Again, SARS-CoV-2 is the proper name for coronavirus, this particular coronavirus that we're dealing with currently. So what's the prediction of a positive PCR test for saying somebody is infectious? So that's the heart of this. And without going through all the nitty gritty, I'll cut to the chase about the key take home here, which is this. So the purple bars here are the positive viral culture, that gold standard to say there's living virus growing inside a patient's specimen right now when it is taken. So critically, they correlated it with what is the time of the test when it is taken versus when symptoms started. Is it symptom day number 5, number 3, number 1, etc. So that is crucial. And the blue is the PCR positive rate. So 60%, 80%, etc. positive rate, also stratified by days after their initial symptom presentation. And the y-axis over here is cycle threshold. So you might have heard this term, cycle threshold, or CT, means how many of these DNA amplifications, these magnifications or repetitions are needed in order to say, okay, now we have 1 billion DNA specimens and we can say a patient's sample is positive or negative. So that is what the cycle threshold means. And what's found over here, the conclusion is that, and what was found from the study is that when you take all these samples that they tested roughly 100 specimens, and they found that after 7 days after symptom presentation, viral cultures are no longer positive. And the reason for that is the patient's own immune system successfully combats and kills off the virus. So the patient is no longer infectious post 7 days in this study, and that's what's been seen in other studies as well, but was seen nicely in this concordance study with viral culture versus versus PCR assay. But look at the PCR test. The PCR test continues to be positive even after the viral culture stopped being positive. So that's why, again, because viruses continue to shed from the body's cells after the immune system gets to work and is killing off the virus, that's why what's happening is that the PCR assay continues to be positive even after the patient is no longer infectious and the viral cultures are no longer reading out with live virus infecting the patient, and therefore the patient is no longer infectious. And so that's the key conclusion here, is that. The second conclusion, as a secondary conclusion, is that if you have to magnify more and more and more. So if you have to magnify beyond, in this particular study, beyond 24 times, if you magnify 30 times or greater, the PCR test might come back positive, but the patient's virus is no longer live in their body. And this kind of makes sense. It makes sense because, intuitively, because what's happening is that, imagine, it's like saying that, okay, the patient's no longer infectious, there's a low level of virus DNA material still present in the patient's body. So let's take a sample, amplify it and amplify it and amplify it over and over and over 30 times, 40 times, get billions of copies of that virus, and then you say, oh yeah, it's positive. But you have to magnify it so many times. Why? Because there's so little left, but the test is still sensitive enough that if you do magnify it enough, 30 or 40 times, then you may still detect it, but you have to magnify it so much because there's so little left, right? So, and then that's why it makes sense logically that the viral culture is no longer positive. If the patient still has live virus growing, you wouldn't need so many repetitions to result in a positive PCR assay. So again, this is a critical conclusion. This is critical data that was published that showed that after a certain time after symptom presentation, the PCR assay may continue to read out as positive because the virus will continue to shed. And that's normal for viruses. That's normal, and we've seen that published in the literature with multiple other viruses like we just mentioned, MERS, SARS-CoV-1, Ebola, Zika, influenza, etc. So because of that, this is not shocking. This is not shocking at all. But this is what's being reported, and it's important to understand the limitations of the test. And the other problem is that when patients go for testing in society, if they drive up to CVS and get tested, CVS isn't asking them or recording did you have symptoms, when did you have symptoms, how many days is it now compared to when the patient got tested. They don't report that kind of stuff. So therefore, we don't know, out of the number of cases that are being reported positive on a given day by the PCR test, how many are actual reflective of perhaps a positive virus culture, like they have symptoms less than 7 days and are now being tested, or they were symptomatic 2-3 weeks ago and now the patient's being tested because they're just worried because, oh yeah, you know what, I had a cough a few weeks ago, and I just want to check. I just want to know, And so that's fine. I mean, I get it that the patient, the individual in society wants to know. I can understand that, instinct. But in terms of the medical value, that PCR test, even if it reads out positive, it is highly unlikely the patient is infectious any longer because so many days have passed since that sick contact, when they got exposed to somebody else with coronavirus, or since when the patient started having symptoms. So that's also why the CDC says beyond 10 days, you're probably not infectious. And it's because of this kind of data, like was published in the medical literature. And again, you won't hear this in the news or the popular, kind of press that's out there. But this is the real data. This is the real publication out there, publications that are out there. And this immunology concept has been known for a long time. This is not a new thing. This is not a new understanding. And it's now confirmed also with coronavirus, like in the study we just talked about. So to wrap up this first part before we go into in-hospital mortality is that, therefore, the raw PCR positive numbers do not equal number of infectious cases. That's a key concept. Now, we don't know the breakdown because people aren't getting virus cultures left and right? So because of that reason, unfortunately, we don't know what it is. But it obviously cannot be all of them. 200,000 people are not all infectious. A lot of them are being tested when they go into hospitals by default. So, for example, if they go into most major medical centers in the United States right now, including in my area, every single person, if they're going for a radiology test, if they're going for a biopsy, if they're going for an outpatient procedure like an endoscopy, colonoscopy, if they're going to the emergency department, for any of those things, every single person gets tested. But the logic for that in the hospital makes sense. They want proper infection bed management. They want to triage the people so a patient doesn't get put in a room who may have active coronavirus with somebody who's negative, because they don't want a disaster on their hands and be spreading it left and right in a population of inpatients who, of course, are going to be sicker. They already have something else going on. So that's why from a hospital perspective it makes sense. But when these numbers get reported in the public, that's where it's very misleading, as you can see. So a positive PCR test does not equal automatically an infectious individual. That time from their sick contact or time from initial symptoms is crucial, and unfortunately that data is lacking. But we know that not every single of those 200,000 or 150,000 that are positive can possibly be all infectious. There's no way. And we talked about that from this data right now. Now, segueing to the second part over here is in-hospital mortality. So what we've also made a lot of progress in is because of this reason of infection bed management, number one. Secondly, because of PPE availability, where PPE availability was very sparse, back in the spring, masks and gowns and gloves were all being rerouted, by the government elsewhere. But because of PPE availability, because of infection bed management, and because of experience and now hospital protocols, we are much, much, much better at helping patients survive. So if they are part of that minority of cases that develop severe COVID. Remember, we talked how the vast majority of people luckily don't have severe COVID. They have very mild coronavirus or even asymptomatic coronavirus, and that's why the infection fatality ratio is far below 1% for the vast majority. But if somebody is unfortunately in the minority that have a severe case and are hospitalized, then those people also are surviving at a much higher rate. And it used to be back in the spring, roughly in the mid-60s as far as the percentage of survival, now in the mid to high 80s. And let me show you that right now as well. And here it is. You can see over here, this is data from the WHO, from Johns Hopkins, where they looked at a few things. The tests performed per week, which are going up exponentially. The percentage of people who died out of those positive tests has plummeted, thankfully. When this data was analyzed. And the focus right now is survival rate once hospitalized. So out of those people, as far as what's happening from spring 2020 to fall 2020 when this data was analyzed, the survival rate went up from being in the mid-60s to the mid-80s. And that is very informative and very reassuring that even if those people who have severe cases are now surviving at a much better rate than they were in spring 2020, because now we have much more experience, we have much more understanding, we have PPE availability, we have proper infection bed management, we have hospital protocols in place. So if somebody gets hospitalized and has a severe COVID case, we know much better how to deal with it. And that hopefully is reassuring for the general public that we are able to handle these cases much better, even if somebody does have a severe case. So anecdotally in my area, one of the major hospitals I work with, the hospital survival rate is about 89% of people who have a positive coronavirus case. Now, related to that, we talked about how in most major medical centers that everybody who comes to the hospital gets a coronavirus test. So this is one of the other problems with mortality is that mortality figures is that we don't know, we can't differentiate based on the data that's available how many people died with COVID and how many people died of COVID. We do know that some people died because of COVID. I mean, that is true. But we don't know what is the breakdown, how many died with COVID or of COVID. And this, I've seen this happen. Patients who died of something else like a heart attack and they also had a coronavirus positive test. And they're, on their death certificate, it might say out of the 4 boxes that you can fill to say what are the things that contributed to the patient's death potentially. It doesn't say necessarily to prove it or to justify it. It just says list diagnoses. So you can list up to 4 diagnoses, and one of them somebody could write heart attack, diabetes, hypertension, coronavirus. So that will be listed in the data as somebody who's coronavirus positive and died. So that's why what the state health databases say is that we're just going to take all the numbers in aggregate and say if they have coronavirus listed on the death certificate, regardless of whether it's truly of coronavirus or with coronavirus as far as the cause of death, we're going to just report it. So it's important to understand the limitation there as well. So not every case that's a mortality event is going to be a true coronavirus cause of mortality. And it makes sense. There are many people who might have coronavirus when you test everybody coming in, but they may no longer be infectious for the same reason we just talked about in that study that we led off with earlier in today's discussion in episode number 2. So to summarize over here, and thanks again for listening today, and hopefully you guys have found this very useful and informative because I think this is an important nuance that you guys need to understand. We talked about how the limitations of the PCR test does not mean somebody automatically has an infectious case of coronavirus. And we know that there is a distinct relationship to the time of symptom onset or a sick contact where they encounter somebody else who's coronavirus positive, for example. And therefore, if a certain number of days has passed, more than a week has passed after those initial symptoms or sick contact, then the patient likely does not have an infectious case. But the PCR test may continue to read out as positive because the virus continues to shed in the body. So it's important to understand that limitation of the PCR test, number one. And this is relevant because this is what's being reported in the public sphere. We're hearing the number of PCR tests that are being reported every single day, but it does not mean every single PCR assay that's positive is an infectious case. They do not equate. Secondly, we talked about how in-hospital mortality has thankfully improved very markedly as well. So now, even out of those minority of cases that do develop severe COVID and are hospitalized, over 80% of them are surviving, in the mid to high 80s now, as we talked about and we showed in a couple figures. And so because of that hopefully is also reassuring that even those that are having a severe case, their chance of survival is actually much higher. And remember, big picture is that the vast majority of people, if you were to contract COVID, if you are part of the 2% of the population that contracts COVID, then your chance of surviving is very, very high, where the infection fatality ratio risk of dying from it is far less than 1% for the vast majority of those that are less than 70 years of age or do not have one of those big comorbidities that we talked about. So that's why these concepts are crucial, and hopefully you guys have found this useful. Now, in our next episode, we're going to go into why the media's messaging and misinformation really is a problem. I think there's a certain responsibility we have to have, in the public, as physicians, as media, as other public figures, to report things accurately and with the right perspective, but also to be reassuring, especially when it's supported by data, objective, verifiable data, like what we've been talking about in our ImmuneKicks series. And because of that reason, we're going to talk about that, why that kind of mismessaging is ultimately harmful to the public, what kind of problems it's causing, like anxiety and stress and other, public disconcerting factors, and ultimately why, I think a change has to be made as far as that goes. And again, this is what has motivated myself and others to put out this kind of messaging out there so you guys understand more accurately what is the real deal. So if you like this video, please feel free to share it. Please hit the like button. Please subscribe if you want. But please feel free to share with any concerned friends and family and colleagues that you guys have, because I think it is crucial for all of us as concerned citizens in the country to understand really what's going on, to move beyond the noise, and really see what's the real deal of the situation out there with coronavirus. And lastly, accurate knowledge is power, like we talked about. So that's also one of our main things here. Our mission is that we want to deliver accurate knowledge, all again, objective data, verifiable, published medical research, that we can say, okay, look, this is beyond the noise. This is the real data. These things hopefully will be reassuring to you that we are indeed on the right track. So again, accurate knowledge is power, and hopefully you guys enjoyed it. See you next time in episode number 3. But again, my pleasure to present to you guys, and have a great one, and see you very soon. Thank you.